Hi, my name is Adam Tyson. I'm a general obstetrician and gynecologist with the Department of Obstetrics and Gynecology at Greenville Health System. The talk today is on uh, introduction to hysterectomy, and as with the earlier cesarean delivery talk that I did, this is really intended for medical students and junior level residents. It's not going to provide detailed instructions on how to perform a hysterectomy, but what we're going to do is look at some of the reasons we do it, some of the risks and benefits, and kind of the theory and the common features to the different types of hysterectomies that we do, really just to provide you a good overview of how and why we do the technique. So in simplest terms, a hysterectomy is the surgical removal of the uterus, and this can be with or without the removal of the tubes and ovaries. And that portion of the operation, if you do that as well, would be designated additionally as a salpingo-oophorectomy. Often done at the time of hysterectomy, depending on the indication for hysterectomy, but not necessarily. So again, most specifically, hysterectomy is only the surgical removal of the uterus. Now, hysterectomy is a very common operation performed in the United States, and despite advances in medical therapy of a number of gynecologic conditions, it's still the definitive, or in some cases, the fallback treatment for many gynecologic diseases. Some of the more common things that we might do a hysterectomy for would be pelvic pain, which is a very common indication. A subset of that would be endometriosis, or in some cases, idiopathic. Another indication would be for abnormal bleeding. And this is often done if the patient has failed medical therapy or has some contraindication or even an unwillingness to undergo medical therapy. Abnormal bleeding you can kind of divide into two different branches as well. It would be chronic or subacute. And this would be by far the more common. And then you could also have an acute episode of vaginal bleeding. And I'll divide this into obstetric bleeding, in which case one might do a peripartum or cesarean hysterectomy, or non-obstetric. I'm not going to really talk too much about the obstetric portion of this today. That's really a separate topic of itself. Has some different considerations and different techniques. We're going to mostly focus on those done for gynecologic disease. A third indication would be for leiomyomas, fibroids. And you could think of this as being an etiology of both pain and bleeding. Pain due to the bulk symptoms, causing pressure, causing abnormal function of the bladder or rectum in some cases, and bleeding due to the abnormal lack of hormonal control over the fibroid. Another indication is uterine prolapse. Just what it sounds like. It's the failure of pelvic support, leading to pressure symptoms. And if a hysterectomy is done for prolapse, it's often done in combination with other vaginal support procedures, such as an anterior or posterior colporrhaphy, or one of the newer combined mesh procedures. Another broad category of indications would be for malignant disease or premalignant disease. This might be done for cancers of the uterus, the ovaries, or the cervix, and for premalignant diseases such as recurrence of cervical intraepithelial neoplasia or endometrial hyperplasia. Okay. So in broad terms, those are some different indications. Many of these have medical therapies that are available as well, others don't, but hysterectomy is often the treatment of last resort in some of these cases. So moving on from the indications, let's talk a little bit about the different types. You could classify this a lot of different ways, but because the terminology is so often confusing and because what patients will say doesn't necessarily match with what we consider the right medical terminology, we'll try to clarify a little bit. So type of hysterectomy. And I'm going to just sort of arbitrarily divide this into the total hysterectomy. And this includes removal of the cervix. You can also talk about a subtotal or a supracervical. And as the name implies, the cervix remains. And I say that the terminology is confusing because a lot of times patients will say, well, I had a partial hysterectomy, and you don't know what they mean when they just say that. What they very commonly mean is they had a hysterectomy, which was probably a total hysterectomy, but that they had their tubes and ovaries left in place. And that's another good point that you have to sort of, if you're getting history from a patient, is that either of these may or may not include the salpingectomy, removal of the tubes, or oophorectomy, removal of the ovaries, or both, the salpingo-oophorectomy. So it's important if you're talking to a patient about her gynecologic history that you try to pin down which of these broad types she had done. Now the indications for salpingectomy or oophorectomy are not necessarily the same as the ones for hysterectomy. You might do all of these things in, for example, a staging procedure for ovarian cancer or endometrial cancer, but in cases of benign disease, particularly in a younger woman, you might choose to leave the tubes or the ovaries or both behind. And that's a separate discussion based on patient's risk factors for ovarian cancer, her underlying disease, and her personal preferences and willingness to accept an early menopause. And then I'm going to put in one other type of hysterectomy. We're going to talk about the radical hysterectomy. And I'm not going to speak a lot about the radical hysterectomy today, except to mention that it is the removal of the uterus as well as the perimetrium, which is the vasculature and the peritoneal connections around the uterus and cervix to the lower portion of the pelvic sidewall. This is usually done in cases of cancer of the cervix, although more advanced cases will be treated with radiation rather than with hysterectomy. So a third consideration then is, after some of the initial nomenclature of what I'm calling the type of hysterectomy, is the route or the approach. And there are a number of different types that you can choose if you're performing the hysterectomy. There's the vaginal hysterectomy, and this is really, if you think about it, the original minimally invasive hysterectomy. And both ACOG and the American Association of Gynecologic Laparoscopy agree that in most cases when we do a hysterectomy, we should consider the vaginal route first, unless there are specific contraindications present which make that dangerous for the patient or are unable to treat the disease that needs to be treated. Things to consider if you're considering a vaginal hysterectomy are uterine size, the disease state, prior cesarean delivery, because cesarean delivery often results in adhesions of the bladder to the anterior surface of the uterus, and can make a vaginal hysterectomy more difficult. The patient's parity is important. A patient who's had multiple vaginal deliveries is more likely to have some decensus of the uterus, meaning there's going to be some laxity of support for the uterus, and that makes the connections between the uterus and the pelvis easier to reach in many cases. Another consideration which relates to the uterine size is just the anatomy of the uterus, presence of fibroids, things like that. Now, all of these need to be considered, but they're not contraindications. You can have a nulliparous patient with a large uterus and even with a malignant disease, and a vaginal hysterectomy might still be the right choice for her, just depending on the skill of the surgeon, the experience of the surgeon, and the type of disease that's present. But these are all things you do need to consider before deciding on a vaginal hysterectomy. Of all the various routes of hysterectomy, this has the lowest complication rate. A short hospital stay. In some cases, it's done as an outpatient, although more commonly there's an overnight stay. And relatively lower cost associated with it. So all of those things make it good choices. Now, when would you not consider a vaginal hysterectomy? If the anatomy is limiting. So, for example, if the patient has a very narrow pubic arch or very shallow pelvis, if the vaginal introitus isn't sufficiently wide enough and you just can't get access to the structures that you need to ligate to take the uterus out safely. Presence of an adnexal mass. Not an absolute contraindication, but if this adnexal mass is present, you need to consider whether you can fully evaluate it vaginally or not. And certainly if it's thought to be a malignancy, a larger staging procedure is going to be needed, and vaginal hysterectomy may not be the right choice in this case. But overall, even in cases, like I said, of obesity, nulliparity, this should still be considered your first choice in many cases.